Hi, everyone. Welcome to Living Well with Dr. John, Adjustment Through the Lifespan. Today, Dr. John Chang will be interviewing Dr. Linda Schultz, commonly known to the Reeve community as Nurse Linda. Now, for some background on Dr. John and Nurse Linda. Dr. John Chang is a clinical neuropsychologist and is board certified in rehabilitation psychology. In addition to having his own private practice, Dr. Chang is a professor of psychology at East Stroudsburg University, as well as a consulting psychologist. Nurse Linda Schultz is a leader and provider of rehabilitation nursing for over 30 years and a friend of the Christopher and Dana Reeve Foundation for close to 2 decades. One quick note before we start: if you would like to ask a question to Dr. John and Nurse Linda during the webinar, please use the Q&A section located at the bottom of your Zoom screen. Now I'm going to turn it over to John. Hi, John.
Hey, Kaylee. Thank you very much for the intro. Uh, we have Nurse Linda there. Hello. And
Hi, John.
a couple of the captioners. Hello there. Welcome, everybody, to our once a month podcast here. We are coming in from the snowy tundra of the Poconos. It has been snowing like crazy. Some of you out there, if you're in the Northeast, give us a good thumbs up on being part of this crazy Northeaster. I'll tell you, maybe I'm getting old, but I don't like snow anymore. Used to like it when I was younger, but it doesn't mean much other than caregivers are not going to show up today, which they didn't. Means my wife's going to have to shovel out all the steps out there, which I feel guilty. I don't know. After 33 years of being in a wheelchair, you think I stopped feeling guilty about not being able to shovel the snow, but I still feel guilty in not being able to shovel the snow. So I hate the snow. But I did have a small video for you to show you what I'm looking at now. If you want to show that a little bit out there, I don't know if you, I hope it shows up. Go ahead. If you can. That's what shows out of my window. See that? So if you're getting some of what I've gotten yesterday, is that crazy? Even my window now is all full of snow out there. So I thought I'd share that with you today. So we are going to begin about talking, and we're going to capture, hopefully, Nurse Linda's incredible knowledge about spinal cord injury. I'm hoping to tap in on some of the main things. Now, thank you for sending in all those questions. And those questions that you send in prior to the talk helps us guide us on where we want to go with this talk. So thank you. And of course, feel free to submit them today. We're not going to be able to get to everything today. I'm picking and choosing what I think may be the most important things to talk about. So you let us know how we do today, okay? Again, this is Living Well with Dr. John, and we have Nurse Linda. And again, I'd like to thank Kaylee, Angela, the foundation, for allowing us to do this talk once a month and bring you some information that is hopefully relevant to your life. So Nurse Linda, thank you for being on today.
Well, thanks for inviting me. I've been looking forward to it.
Yes. You and I have been sort of bantering back and forth over the past few months on different topics. And so today I like to talk about, obviously, every sector. I mean, I have a million things in my head that I want to talk about. But for now, let's focus on, if we can, about, let's start with children. And, in your experience, in the experience of people younger than 18, what are some of the things that you have noticed that, are relevant to your experience about children and adolescents with spinal cord injury?
Well, when people have children, they tend to place all their hopes and dreams on that child. They have an idea of what that child's going to be, how they're going to grow up. Now, that's just normal parenting kind of thinking. It never turns out quite that way. But you, when you hold that little baby in your arms, you're thinking, oh, this baby's going to be this and all these different things. So when something happens, either before birth, at birth, maybe there's some kind of genetic issue that's going on,
Mhm.
or after birth through accident or through some medical cause, and something happens to the child that changes the life trajectory. And it seems to me like dealing with parents and that guilt that they have, it might not have anything to do with the parents, but boy, you can really wrap it around and turn it right back on you as far as that guilt. And you were saying that you have guilt of not shoveling the snow after all these years, and parents seem to be in that same boat where they just worry and worry and worry about their child and things being different. And it's just this overwhelming guilt that people have. And
Yes,
how to deal with that, how to get, I don't know if you can ever get past it, but how you can harness it.
yeah. In psychology, one of the best predictors of how well child will do is how well the parents manage the disability in their heads. How well are they going to accept and move forward in raising that child with a disability? And that is the best predictor of long-term adjustment for people. So yeah, that guilt, the process of figuring that out, as you're moving on. And but are there any specific medical things that tend to happen for younger kids or adolescents that we should be thinking about if we have an injury early?
Well, if you have an injury really early as a small child, say before the age of 3 or 4, that child's not going to really remember what life was like before they had the injury. So they don't have the big loss of, oh, I can't walk, or oh, I can't do this or that. They don't have, the parent has the knowledge of that because they have their own experiences with activities, and but the child really doesn't. And so to try to make things normal for that child, this is the way that, this is the way you toilet. That's just the way it is. You do a bladder program, and to make that child feel like that's normal in for their unique way. I always have to kind of laugh when you have little kids come into clinic or whatever, and they'll be talking about the other kids in school, and the other kids don't use a wheelchair. And
Mhm.
isn't that too bad for them? Or the other kids don't have a brace or don't have, whatever device that the child might have. And
Mhm.
they kind of feel bad for the other kids. It's a whole different way of thinking.
Yeah, yeah. So I mean, to them, that is their life. They,
Yeah.
they don't have something to compare to. So once again, it's the parents that are struggling between what they think they should have had or what they could have had. Whereas a child, this is my life, and this is how I am. And it's funny you say that, because when they ask about quality of life and they compare what the parents rate the child has and what the child rates. Parents traditionally rates the child having a less quality of life than what the child actually expressed. So, so they're having less distress than the parents, as you said. So that is their norm, correct?
Yeah. And it's really hard as adults to not see that, to not see deficit, deficit, deficit instead of positive, positive. So getting them to think in a different way of trying to change. Well, okay, you had this child, and you were gonna have them grow up to be a famous baseball player. That's every parent's dream, is that their child's going to be something, very spectacular.
Mhm.
And so how can you alter your thinking to they can still be spectacular, but maybe in a different way? If you want your child to be a great operatic singer, they can still do that. Or maybe um, they're instead going to change to production or design or something. So, it's really kind of expanding your mind if your child has a disability or if they don't have a disability, because, not every single child, no matter what their situation is, going to grow up to be, an Academy winning actor.
Right, right, right. And when you say growing up, it's funny you say that because in on average, a child who grows up with a disability uh, transitions to an adulthood usually in average has a higher education compared to the norm of people in the United States. So they tend to be actually more educated and at times have a higher income than the norm because they are been so focused on academia and job at times since they're young. But medically, I read at times that when you're young, you have to worry about you know spinal issues, being that you're still in the developmental process, maybe some hormonal issues. Is that correct? Can say that these are major issues?
Oh, definitely, because a growing child still has a lot of potential to develop in different ways. So you want to make sure that their health is the best that it can possibly be. Like you're saying, hormonal issues could come into play if something is not being stimulated in the right way. I think, it all comes down to the nervous system, and a child's nervous system, when a baby's born, their nervous system isn't fully developed like we adults are. We kind of get hardwired the older we get. And so children have much more potential because their nervous system is still developing. So maybe they have some difficulty with doing a particular activity, but they still have some opportunity as their nervous system develops that they might still be able to capture that particular activity. Or I think that one of the challenges in the whole developmental process is that there are milestones for children as they grow, and they're supposed to reach different milestones by different age, and then you can tell that their development is going okay. But if a child has a spinal cord injury, they might not be walking, so they might not be walking by a certain age. So you have to adapt those developmental milestones. So are they independent in their wheelchair by a certain age? And healthcare professionals that work with individuals with neurological issues, we know that we need to make those adaptations. But the general pediatrician might not know that, or the school people might not know that. I know in healthcare, one of the big issues for children or even older teens or as they get older is that the parent is so wanting to be a parent. I will help you do everything because I see you struggling, so I'm going to step in and take over. So one of the developmental milestones is to be able to toilet by a certain age. Well, that might not be possible because you're doing a bladder program, and for a child to do a clean bladder program can be a challenge because they're waving the catheter all over it. Suddenly becomes a dinosaur or something, and so it's kind of hard to focus them on the task at hand. So we generally have kind of a guideline for ourselves, like the child should be able to either catheterize by the time they go to school or be able to direct somebody else to catheterize. Because again, we're trying to make the child's situation what is going to be normal for them. So, it's not that it's different from everyone else. It's just that this is the way you do this as a unique person. We all have uniqueness about ourselves.
Right, right. So I guess one of the things that you have to really worry about is to be too much of a parent or not allow the child to be independent. It's about what I'm hearing from you is that we may have a tendency to smother the child because we've been doing a lot for them growing up, and being that they were different, they're disabled, a child with a disability. So you're saying that you want to tailor to every individual's unique
Right.
ability, I guess, is every
Right.
child is different.
Right. Every child with or without a spinal cord injury, they're all going to be different and all have different needs. And parents all have different styles of parenting. Some are very rigid, some are loosey-goosey, and some like to hover,
Mhm,
to kind of keep that in check and let your child be what they're going to be.
right. And all those milestones that you're traditionally thinking about are goes out the door. in a lot of ways in
Well, I
initially.
don't know that they go out the door, but you have to think about how you can modify them
Okay.
so that the child has a milestone that's unique to them. So, you know, some children are small and maybe they can't manage their wheelchair. So instead of using the walking as the parameter, can they manage their wheelchair, especially if it's a power chair? Now, kids are pretty adept to electronics because, you know, especially now they're all playing the video games. So they understand a joystick
Hmm.
probably better than than I do, but you know, to adapt those kind of things to make your child have meet with success, but on their own needs and terms.
Okay. Okay. You know what? One of the things that I, as a psychologist, we look at participation. That is one of the litmus things we look at to see uh, how well is a child doing with their disability as they're growing up or getting older. And part of the things we look for is, are they participating in the world, the community? Are they integrating with activities, both informal and formal activities? Part of organizations, part of teams. So that's how I look at it from my perspective as a psychologist. Are there any litmus things that you tend to look for as a child's growing up in when it comes to independence, bowel management, ambulation, any of these things as as they get into a teenage years? Are there things that medical people look for?
Well, definitely, we hope that they're managing all of their care by the time they're, oh, probably in those tween years in the 10, 12 age group. Now, that doesn't mean, oh my gosh, you know, my child's 13 and they're not doing that yet. Again, it's kind of unique to each individual child, but we try to think of the responsibilities they have as being um, as them being able to do it in an age appropriate sort of way. So a child might still need some reminders to do some pressure releases, or
Hmm.
they might need to be checked on their bladder program or bowel program. Kids go through different periods too. Some kids as adolescents get to be really kind of rebellious and they're not going to do pressure releases and they're not going to do their bowel program and they're not going to catheterize themselves. And as a parent, you know that this has to be done. So, you know, you don't want to get in one of these power struggles. And you probably have a lot of suggestions, John, about if you get a child early on and use, well, this is just the way it is and the child adapts, oh, that's great, life is wonderful, that hardly ever happens. But you keep trying to reach that goal and make the child be independent on their own. But there are days that people just, I just don't want to do that. A child, a teen, an adult, I just don't want to catheterize today. But it has to be. So changing that mindset, but especially in those teen years, you'll find a lot of rebellion. Some kids, they don't rebel too much. Their
Right.
rebellion might be, I'm not going to eat that vegetable. And, that's a pretty normal thing. But some kids, have a little more struggle with adapting, especially if their injury comes on later.
Yes.
So as a psychologist, that's when we call you, Dr. John. We need some help here. This parents need some help.
When I get a frantic parent that calls me or asks me for my advice, my usual go-to would be pick and choose your battle. Don't fight all the battles because you're never going to win all of them. So just pick the ones that you want to win, and those are the ones you go after. But please don't fight every battle, because if you fight every battle, you're going to lose most of them. So
Mhm.
so that's my go-to answer. But you're absolutely right. You mentioned briefly though that I've seen I've seen clients where they had the accident later on as a teen or even as an adult. They versus growing up in a wheelchair, growing up
Mhm.
complete. And I do notice that there are some interdependence, dependence on the caregiver more at times when you have always been um, in a person in a wheelchair. Have you noticed that, or have you seen that that contrast at all? When
Oh, definitely, definitely, because I think, it's just, I think that it's when somebody has an injury, it's just so overwhelmingly difficult. And there's so many things to do, and something that for a person that does not have a spinal cord injury, if I were to think I have to go catheterize myself now, or I have to do a bowel program now, it doesn't have the level of intensity. I would like to hope I'm a little more aware um, of working with people with spinal cord injury, but sometimes I think that people think, oh, well, you just go in, just go catheterize yourself. But it's really difficult to get the supplies, to get your hands cleaned at the right time. It can be very time consuming. And sometimes we let tasks just overpower ourselves. There's so much all at once, especially until maybe you get a little bit more into it, get a little bit more of the routine, figure out, where am I going to keep my catheter where I can always reach it? My bathroom isn't set up for that. How can I adjust these things? It's really such a process. And, for some parents, like you were saying, don't fight all the battles. If a child doesn't want to catheterize for a while and you do it for them for a while, that's an okay thing. But just know that you have that goal that we're going to get back to it and you're going to
right,
do this
right.
on your
I
own.
mean,
'Cause
ultimately, yes, yes,
yeah, kids want to go out. They want to do things with their friends.
yes, absolutely. So they need to know that as part of their life requirements.
Right.
Shifting as we shift into an adulthood or young adults. I remember one of the when I had my injury at 19 and moving into my early years, a young adult. I thought that the dumb catheters, those external catheters, they used to pop off all the time. And no matter if I was in college or in class or if I was out with my friends, or they would just pop out at the worst times.
Mm-hmm.
I didn't want to have an internal catheter because I know that was even worse for UTIs. As an adult, as in general, I'm sort of forcing you to know all your knowledge of 30 years into like 10 minutes here, but of as an adult living with a spinal cord injury, what are some of the medical things that you have been exposed to that you thought are that we should learn, or for some newly injured people or some people who maybe are already been through it for many years? What are some main things that we should do well in order to live well? What should we? I already heard you said having good hygiene is key, one of the key things.
It is very key.
Yeah, what are
Yeah.
some of the other things that you could tell us?
Well, you kind of make me laugh a little bit because, yes, the catheter will leak at the most inappropriate time. And you'll have a bowel incontinence at the most inappropriate time. And
Yes.
at first, at first, when somebody has a bowel accident, and gosh, it usually happens maybe in therapy because they're moving around or whatnot. And they'll be like, boy, that therapist has a lot of gas. They'll come back and tell you, my therapist just had a lot of gas. And then, but now I'm back in my room and I can still smell that. And it's like, oh, wait a minute, it wasn't my therapist. Whoops, it was me. And oh, the horror.
Yes.
So it's those kind of things that are make you more aware. But the big three things you have to do is monitor your skin and do your bladder and bowel programs, but also eating well. So people like junk food. It's made to trigger your brain to want more junk food. Um, and that can cause problems with your skin, your bowel, your bladder. Um, People who have spinal cord injury have a higher risk of diabetes because
Mhm.
they're not using their legs as much. So I think the number one thing, the skin, bowel, and bladder you have to do. Okay, but I think the number one thing to do is to move your body, because traditionally rehabilitation has been learn to get out in and out of the chair, learn to catheterize yourself. Okay, you're independent now, go home. But rehabilitation is changing now that people are looking more at recovery. We know recovery is possible. So people are looking more at recovery. And I think, moving your body when it's difficult to do that is a challenge.
Mhm.
And some people can't move their body, so they have to have somebody else do it for them, which is another layer of uh, difficulty, to get somebody to help you do some of these activities. But in my personal view of the world of spinal cord injury, I think movement is probably the keyest activity of all.
Yeah, so hearing, if I heard you correctly, and some of the things you're mentioning is actually giving me PTSD here when the things I had gone through in the 33 years, but activity, staying mobile, moving, either physically doing it yourself or having someone else helping you passively range. So being active is one. Two is bow and bladder, making sure you do both of those well. Those are at least some of your top three, you're saying then,
Oh yeah, and skin checks.
and skin checks. So
But below the level of the injury, your nervous system is quiet. It's not getting any input. It's not able to send messages to the brain. So it's really pretty quiet. But when you provide input to those nerves and muscles below the level of the body, you're providing that input to your body. If you think about it, while somebody's moving your legs or moving your toes or doing even passive range of motion, if you think about it while they're doing it, oh, my leg's going up, now my leg's going down, my knee is bending. You're sending a message down while your body's sending that message up that it's moving. And hopefully at that spinal cord injury, you'll make some kind of connection there.
yeah, that famous connection at that spot. Now, when I said you were, about PTSD, I remember when I was just newly injured down in McGee Rehab in Philadelphia, and I was laying there watching it, and I saw this. This was about 4 or 5 months into my injury, and I heard this rumor, this guy was coming. He was like 25-year post injury. And I was like, oh my God, I gotta look. I gotta see what this guy looks like. And he rolled around and I saw him coming. And first thing I noticed is how big his belly was. I was like, oh, that's huge. I was like, now that I'm 33-year post and I got the same belly that the dude had when he was back then, I was like, man, now I get it. I should have watched my weight a little bit more. And you said diet. What are you putting in to yourself is really important. And
Right.
because you don't want to get heavy while you're in a wheelchair, correct?
Right. It makes it more difficult for you to move around. It makes it more difficult for people to move you around. But remember too, that big belly, some of that is not because it's just fat tissue there. A lot of that is because your muscles aren't responding in your abdomen. So getting a six pack is going to be a challenge because you can't really work those muscles enough to get that to happen. Now, some people do have some success by using electrical stimulation. But not everybody can get that. And I used to talk more about electrical stimulation than I do now, because people would get so annoyed. Yeah, I would love to do that, but I can't get it. But it's becoming more and more affordable, and it's becoming more and more the treatment of choice. So it's not really easy to get right now, but I think in the next few years, we're going to be seeing more and more of that.
When you say electrical stimulation, are you talking about like ab stimulators, like small units? You're not talking about the FES bikes that you're riding, are you? Or are you talking about both of those?
I'm talking about all of it. The FES bikes came out and they were developed in Cleveland. And boy, what a thing that was. But they were so big. If you had one, if you were lucky enough to get your own, you would have to have your floor reinforced because they were so big and heavy. You would have to have a room just dedicated to this device.
Right,
You know,
right.
and it costs as much as a car, a fine car, not a cheap car.
Yeah, that I was gonna say that's expensive car.
Yes. And so it was very difficult, but to get one, but people got those and they used them. And then newer devices have come out. They're a lot less expensive. We're going to see the prices go down even more. But there's new research out that has indicated that if you even get one of the TENS units and use one of those TENS units, that you get some benefit. Now, it's not the high powered repetitive like on the bike, but we don't know that it's not either.
Mhm.
because we don't really know what we call it dosing. So like you have a dose of medication that you might take for some problem that you have.
Mhm.
But what is the dose of time that somebody should get e-stim? We don't really know that for sure. And so, you don't want to be on it, get an e-stim machine and just have it go 24/7 because you're going to wear out, people don't move 24/7. We rest our muscles and nerves and that at times too. But there's starting to be some evidence that these smaller TENS units and just attaching that, you can get them on Amazon.
Right,
Um,
right.
but, you don't want to just get one and start stimulating yourself because you need to make sure your bones are healthy enough that you're not harboring uh, um, a blood clot somewhere that's going to release and kill you. So you need to check with your healthcare professional. You need to get advice from a physical therapist, where to put the electrodes, how to do it. But there's getting to be a lot more of that. And of course, with all the research going on now, these implanted stimulators are really showing dynamite results. All the results are not in, but what little they have been able to release from some of the pilot studies, as you know, John, in research, you can't release the results until the study is complete because it checkers the outcome of the study. But in the pilots studies that they've done, the results have been so phenomenal that it's so past expectations.
Right, right. In my experience with, well, a couple of things. FES, I remember back in 1990s up at University of Connecticut, they had one of those sitting in one of the physical therapy department rooms, and I was allowed to go on and ride that thing for a couple. I think I did it for a couple of months, and I could barely get a minute or two on that bike to really get my legs to do anything. But one time, I don't know, all the stars aligned or the planets were all perfect. I got a 25-minute ride out of my legs. And I haven't seen those legs work like that in years. And I was elated. I was like, oh my God, the things actually moved, actually worked. And then after that, I never got to make those legs work very well anymore after that. So that was my experience with FES.
But what we also don't know is with just the activity of just somebody moving your leg for you, that is still providing that input. So, I think that movement seems to be the key.
Well, we know through that treadmill work that they do with where they get people on those slings and they walk them on those treadmills, that the spine itself knows how to walk. So there are
Yes.
some research to say that walking does not have to be all in the head. It's almost so, but I don't know enough about that. But I have to also admit personally, I did try some of those electro stims on the belly there, and I was like,
Mhm.
oh man, I gotta get rid of this big belly and put those things. But I was a little concerned because I didn't feel down there and I wasn't sure if this is causing me more problem. I have such a history of
Yeah.
autonomic dysreflexia. And I was just like, you know what, this is going to cause me more pain than I want to. So I was like, I better give up. But,
Yeah,
speaking
you
of,
don't want to take off on one of these tangents and just be like, yeah, I'm going to try that. I can get that off the computer and I'll just go do that. Most people have overlooked the fact that they have 2 weeks of mobility training every year in their insurance plan. If it's a private insurance or if it's most Medicaid plans, they have 2 weeks of mobility training. So people think, well, I've got the spinal cord injury. I won't be walking right now. But
Mhm.
you can still use that 2 weeks of mobility training to try things out like the treadmill. Now, you're not going to probably be able to get one of the harnesses and you can use any treadmill, but the device and the robotics to move your legs, it's all horrifically expensive, but you could try that out in your 2 weeks of mobility training, or you could certainly learn to do some FES just using a local device. So that 2 weeks is very important. It doesn't have to be, mobility training doesn't have to be walking. It can be the steps to lead up to walking.
Now,
Another thing that's really important is that standing frame. People should be using the standing frame to keep their bones healthy.
yeah, you're saying something I've never heard. You're saying that our insurances have of 2 weeks of mobility train. I have never known that all the years
Mhm.
I've been
Mhm.
that we had that.
Yes, most insurance policies have 2 weeks of physical therapy. And every year is allotted in your policy. So I don't have a spinal cord injury, but if I had anything else, I could go 2 weeks probably as an outpatient. You know, it's 2 weeks worth of time. It could be spread out 1 day a week for several weeks, but you could go to a rehabilitation center or physical therapy center and work on some of the issues or try out some of the new equipment. And then when you get results from that, like you did that 1 day, you can ask your physician to write a letter of medical necessity to request the insurance company to access that equipment for you. So, but you have to know when the physician writes that letter, it will come back, no, you can't have it. It's when you have to write a second letter and a third letter, and you have to keep going. But if you have the results from your 2 weeks of therapy that you got some success or you had a positive outcome, that just builds the case for why you need this particular therapy to do in your home. You're not going to be able to go to the therapy center and have it forever. And people, think, well, my therapy's over, so now that's just over. No, you have to keep initiating that on your own and doing your therapy on your own at home. So I think people think my therapy time's over, so they stop doing their activity, but you need to keep going.
So perseverance and being informed about how to work with insurance and also taking what you learned at the clinic and try to translate at home. If you
Right,
can.
right. And what if you have that 2 weeks, talk to your therapist. What can I do for a home program? Maybe it's range of motion. Maybe it's working with some bands or some devices, or sometimes the therapist can make some loops on your legs so you can use your arms to move your legs and, at least definitely get the standing frame. Some have gliders like skiers do. So when you move your arms, if you have light arm function, it can move your legs. So yeah, knowing what's available to you out there, and then you've got to be like a dog with a bone and just keep going for it and going for it.
Going forward.
There's a man on my TV locally here. He was on TV because he got an FES bike. He worked with his insurance company for 6 years, but he did not give up. And then 6 years later, the insurance company, I don't know if they got tired of hearing from him or what magic, but he went on TV because he said, you've got to just keep hounding your insurance company. You've got to be a nice pest. You can't be obnoxious because, that turns people off and then they don't want to help you so much, but you have to be a very nice pest and be very, find out who your case manager is at the insurance company and see how they can work with you.
Okay. Now, as we transition into older adults here, I'm sort of shifting gears on us, and there's two things I think about is what is it like to live with spinal cord injury for long term, like myself, who's 33 years post injury, or who's someone who is newly injured as a geriatric, someone 65 and older. We see that spinal cord there's a prevalence of people who are starting to become elderly with spinal cord injury out there, and due to either spinal stenosis or falls. And as I've read that, when talking about an elderly person who has spinal cord injury, it talks about a lot of physical failure to their function quicker than someone who has it when they're younger. Can we talk a little bit about that? How
Sure.
if the basic body seems to give up even quicker if you have an injury when you're older?
Well, I don't know. Well, as you know, when we get older, we have a lot more issues with our body. Our body slows down. You get a little arthritis, you get a little this, you get a little that, a little hypertension, in their American culture, the elderly have a lot more diabetes than younger people, the type 2 onset of diabetes. And so there's a lot of issues there to begin with. So it becomes more difficult and more challenging just to do things like, and, you know, as we age, we notice ourselves kind of slowing down a little bit. Maybe we can't walk as fast as we used to, or, you know, we got the rheumatiz acting up in our shoulder when we get up in the morning. So there, you know, maybe some cataracts in the eyes, you know, maybe some hearing loss. So there's all kinds of things that happen. So it just makes more hurdles to step over. But I think, you know, the group of age 75 and older now is our fastest demographic growth of spinal cord injury. It used to be in the younger young adults, teenagers and young adults, especially from diving accidents and car accidents. But now it's that age group of 75 and older, and it's usually a trip and fall because somebody stumbled over a throw rug or something, or they got up in the night and the light wasn't on, so they kind of stumbled and fell, and they usually hyperextend their neck, and that's usually the source. And unfortunately, what happens is when people who are older have spinal cord injury, what happens is they don't get a time in the rehabilitation facility. They're automatically sent over to a long-term nursing care, and you know it's really can be depressing because you're not given any kind of hope. So that is an issue. I think we've lost Dr. John.
I'm gonna call him right now and hopefully he'll be able to.
Okay, well, I'll just blab on then, because as you know, I never have trouble blabbing on about something. Oh, I see he's coming back now.
Okay, we're back.
Yeah, you're back now. Must have hit something. So I was just saying that, you know, people with that are older are given, I think, less opportunity than younger people. But now I think maybe you're frozen. So I think that as an older person, you need to have your children aware, your friends aware. Be sure and talk about long-term planning. You know, it's not usually that, you know, people will in older age will long-term plan about their funeral or things like that, but they don't really long-term plan about what happens if I fall down and I have a spinal cord injury. But you can talk about if you have, you know, you can get a living will and map it all out. If, you know, if do I want ventilatory care? Do I want all these different things? You know, when you're mapping that out, it's difficult to say. People have different ideas when they think that these things aren't going to happen than when it actually happens. And so I think if you can find an advocate for you that can help get you into a rehab facility and not just say, well, you know, we're going to have to put you in long-term care and that's your only option. So, you know, you always have to have an advocate.
Right.
How old you are.
Okay. So again, I apologize for the luxury of technology. I was in and out. They're blanking out on you. But so, you know, one of the things that I know that as psychologists, the things we teach, you know, with children and parents, we teach a lot more about participation and getting the child out there in the community and integrating. With an adult, especially an older adult, we tend to teach more about problem solving because you're constantly facing problems with your spinal cord injury. And if it's a bowel issue, if it's a wheelchair issue, so problem solving is an incredible coping skill that is necessary to adjust well when you're older. Being able to sit down and problem solve the issue at hand. So with that in mind, let's see. We're moving on to quarter of, and I want to make sure we address some of these questions that was sent in from some individuals out here. So I'm going to throw some questions for you, and some of you have already touched a little bit about. So from Robert out in, he asked about, you know, what is the best thing I should know about my bowel management? What is the key thing? Because that's the biggest issue he has in adjusting to his spinal cord injuries is bowel management.
Well, Bowel management is what we call it now. Bowel program is what we call it now. Back in the day, years and years ago, we called it bowel training. And I'm not so sure why we changed it, except for maybe to make it more politically correct or something. But I think that that idea of bowel training, that idea kind of has gotten lost. So that the idea is that you train your bowels to work at the certain time every single day. So some people try to fit their bowel program in their day when they have time to do it. Then the bowel doesn't get regulated. So the bowel is it's a very complex organ, but it's very rudimentary. So, some people get up in the morning and they have their coffee and they have a bowel movement. Because especially first thing in the morning, there's a reflex that when something warm hits your stomach after your stomach's been empty all night, it triggers your bowel to start working faster. It's called the gastro, meaning up above, digestion, colic reflex. So it makes that bowel, it stimulates that bowel to go. Now, if you're in the working world, you will smell the effects of this reflex. If you're in the working world and you go to the bathroom about 10 o'clock, you will notice the smell in the public bathroom because everybody's had their coffee and now they've had a bowel movement. So the same thing is the idea of this bowel training to get your bowel to work. So sticking with the same time every day, getting that nutrition that you need, getting the fiber, hydrating yourself well, which can be an impossible task when you're limited by an intermittent catheterization program because you're only allowed to drink so much in between catheterization so as not to overfill your bladder. But you can get hydration from other ways, like from eating different foods that have a higher water content, eating plenty of fruits and vegetables, taking fiber if you need that. You don't have to buy the fiber in the store. It has a lot of sugar in it. You want to look for the low sugar items, but you can go to or order online or go to the health food store, which we can't do now because of COVID, but you can buy psyllium and just take that raw psyllium. You can sprinkle it on a salad. You can put it in your drink. And it works just as well. The other thing is people who have higher level injuries. So those that have cervical and thoracic level injuries, your body becomes overly spastic. People do their program, they want to get in and they want to get out quickly. So they start doing that digital stim and they just do it as fast and as quick as they can possibly do it. When you do it fast and quick, you're stimulating a spasm in your rectum. So those sphincters are going to close, which makes your bowel program much, much slower. So be very kind and gentle, be slow, take your time, and be sure and relax that sphincter. Now, if you have a lower level injury, then your body's flaccid and you're going to rely not so much on suppositories, but on manual removal. Again, you want to be careful, be slow, be cautious. You don't want to cause any trouble in your rectal area that will, like hemorrhoids or bleeding or other fissures or problems. So you just want to be cautious. I think, when people first hear the idea of a bowel program, they're like, now what now? What are you talking about here? Nobody's ever heard of that before. That's a unique thing.
Right.
Cautious.
So what I'm hearing from you is that have a good diet, eat a lot of roughage, I used to drink hot water right when I get up just to get things moving. So similar to that, drinking that coffee in the morning, get the bowels moving. But what I'm hearing from you really actually is two things, is that one, be kind to your anus is what you're saying, because it's a gentle thing. And two, don't ever visit the bathroom at 10. Don't go to the bathroom at 10 o'clock in the morning in the business, because that's the worst time to go. So you got to make sure you never go during that time. That's what I'm hearing from you. Okay, so
all right.
That's something.
You got the main message, John.
Avoid the 10 a.m. bathroom time, people out there. If you heard anything today, do not go to the bathroom, public bathroom at 10 a.m. in the morning. That's from Nurse Linda. Now, I do have a question. An overlap between our fields here, Nurse Linda. Coming from Todd here in Texas, he says, one of the hardest things that I have is asking an attendant to assist with my bowel program, It's the most difficult issue for me to adjust to. Um, I'm a consumer directed attendant care. I recruit my attendants during orientation. I've learned to make it clear that as a potential employee, he writes, you need to do digital stimulation with my BOW program. His question for us is, what type of stool software would you recommend for good elimination? And then as well as, this is important to my health, but it's embarrassing as hell to ask an attendant to do digital stimulation. What can we what advice can we give Todd today about that issue?
Well, I can tell you Colace is a good softener, and Senna is another product that a lot of people use. So that's, the psyllium, if you take fiber, that makes the stool very large amount. And so that's easier to pass because it retains a lot of the moisture in there. So that makes it easier. As far as the embarrassment, that is something that I'm sure, John, you have a lot of comments about. It's very difficult to talk to some people about some activities, and to ask somebody to do some activities for you it can be a real challenge. But, again, this is what is normal for you. And so, if somebody's not willing to do that, then you probably need to look for somebody else, because, it's so key that you get that so you don't run into other complications like an impaction or, all kinds of different things.
Yes, it's critical for when I used to hire people that you lay it out there. You don't want anything to be a surprise, because if you want them to, you want to know the hesitation before you hire them. Granted, sometimes I know you don't have a choice and you got to hire wherever's available, because it's not like people are knocking down your doors to want to come and do your bow routine. So, but you're limited who you're being interviewing. But if you are interviewing someone, you need to gently say, look, this is what is sort of, and you for me, I explain to them, this is how my body works. This is it's a practical matter. It is not you try to avoid looking at it as a disgusting thing, but more of a something that you have to do every day, that you're relied on to do. You have to survive in order to do it well, right, Nurse Linda? So,
Oh, absolutely. And I think if you can write out or type out or have somebody write out for you the BOW program, this is when it starts. So you have, so that that person knows that at this time we're going to do the BOW program. You can choose whatever time you want, but you got to stick with it. And so we're going to, you're going to insert the suppository, and then you'll transfer me to the commode after so many minutes. And then you'll do the digital stim. And then at the end, you'll have to do a digital check to make sure the rectum is empty, and just put it all in there. Because, sometimes people are going to come in and say, oh, I don't think we need to do the dig stim today. Yes, you do. That's a part of it. So like you say, letting them know, and let them know, and here is a copy of my BOW program. This
yes.
is what has to be done. Check, check, check.
So having some written material, even written material that you can hand them to read, to say, this is what I do. And so they have some facts and figures that, why I have to do that. Moving on to, I know we're starting to get close to our time limit here. So I want to get some more questions in. Kathy from Texas had a similar question to Joe from Virginia. The most difficult thing of adjusting to my life is the loss of independence. And I was hoping you can talk a little bit about your take on what is it to compensate for this significant loss of our independence.
Well, that is a real challenge because, it's a mental shift that you have to make, and nobody can make it for you. It's just something that you have to think about, that you're doing things a little bit differently, and to know that you're still in control. You're still in control of your body. Nobody should just be, picking you up and moving you around or doing, they should be telling you what's going on. So you maintain your independence of I'm going to do this now, or choices, that you have if you want to participate in something or if you don't, knowing that there's still things you have to do to your body to keep it healthy. But it can be a real challenge because that loss of independence is so difficult. I knew one patient that was a real motivated, real high power, always on the go kind of guy. And then he had a spinal cord injury and he was sitting, and he said patience was the hardest thing that he practiced every day, trying to get that patience. Because, when we want to do something, we just go do it right this minute. And to have to rely on somebody else and ask them if they could, and, wait for them to get up and go get it, it's kind of like, oh, come on. So, it's just a really hard thing, but I think that talking to people like you, John, and trying to work with families and getting people to understand that, it's just a different way of having to adapt to your life around you. What do
You know,
you?
yeah, for me, it's my routine's like 3 hours in the morning, and after 33 years, I still seem to not have a perfect take on it. I have to admit, I in the mornings, I'm always trying to figure what can I do to distract myself in these everythings I have to do every morning. Because when I wake up in the morning, I know it's not going to be another 2.5 to 3 hours until I get in my chair and I get my day going. So I try to listen to podcasts, I listen to music, I listen to books on tape. I do everything in my head to distract my head, to say that here's my routine again for the I don't know, the 23,000th time again. Um, I'm glad I'm alive. Don't get me wrong. I love doing what I do. I get to meet great people like you and Linda, and being to do the things on foundation. But my God, the loss of independence and having to rely everything on somebody is so frustrating. I don't know if I can ever say I completely get over it, but I have found ways to distract myself. And that's when I was younger and I was going through my education, I spent that time reading. If I have to sit on this toilet for an hour, I read what I needed to read a little bit at times. So yes, so I again trying to make it more productive than just losing time and having to do something. So um, you know, we are almost out of time. Kaylee, are there any questions that from the live chat that you thought we should answer?
I see a couple questions so far. The first one is, and forgive me if I say anything incorrectly, it's can osteogenesis stimulators be used to maintain bone density as an alternative or addition to standing frames?
Well, I'll field that question.
Yeah.
It just depends on what your situation is. The standing frame is the best because you put your body weight through your bones. But if you are for some reason not able to stand, then you could try a bone stimulator. Um, they're usually used more after like a fracture, like if somebody breaks their bone, because it will stimulate the bone to heal. I'm not sure how much it just stimulates the bone to carry on its calcium depositing and uptake and that sort of thing. But if you check with your healthcare provider, it might be an option if you cannot stand. Standing is the best if you can get a standing frame.
So that natural gravity on your own weight sounds like it's the best thing for you, the standing
Well,
frame.
and it's a normal process.
Okay.
It's the way the bones understand how to work. If they're being stimulated in some different way, it's kind of a little different physiological process. And so if you had a bone stimulator and you always put it in the one place every single day, you could get too much bone. So heterotrophic ossification is a problem that people have with spinal cord injury, where the bone kind of forgets how to do its turnover. So, everything like your skin cells turn over, your bone cells turn over, your nervous cells turn over. So your nervous system is constantly regenerating, trying to heal itself. And So if you use one of the bone stimulators, you could be stimulating the bone to grow out into the muscles, which is this heterotrophic ossification, and then the joints become stiff, and you can get other problems because you have bone growing in your muscles, and it has to be surgically removed. There's medication that you take for it. It's just a problem you don't want to have.
Right, great. Thank you. You know, one last more question, and then we'll Kaylee, do you have one last question?
Yep. The last question is, what's the most common practice for
Okay.
helping a child?
Oh, can you say that again? We lost you for a second.
Were you able to hear me?
No, can you say it again? We lost you for a second.
It says, what's the most common practice for helping a child with bowel management?
Well, I think that the way to start is to walk through every time you're doing it, to walk through what you're doing, even when the child is very, very young, but especially as they're older, to say, the bowel program time. First, we start with, insertion of the suppository. I'm going to do that now. Then have them watch with the mirror, and then you can have them eventually do it themselves with, help guiding their hands, and, see how the setup is arranged. And, even the smallest child can go get the gloves, or they can, get the supplies or whatever. So just incrementally adding it in until they can do the process on their own.
Yeah, and from from a psychological perspective, remember the issue is probably harder on you than it is on your child. This is maybe part of their life. This is something maybe they've just grown up to understand. But you are struggling with every aspect of it because this is not what you grew up with, and this is not what you're traditionally feeling like. This is what you're supposed to be doing as a parent. But given that you are taking care of that person and that little kid, and you're doing everything you can, you just need to say to yourself, you're doing the best you can, and that that person that you're helping, that little kid that you're helping, give that thing as much love as you can, and try not to stress out too much about it, because they're already thinking that it's just part of their life. So I would like to finish this Living Well segment with one shout out to Stephen McIntosh in Texas. I want to read something that he wrote. Stephen says, I'm sorry, I apologize. It's not Stephen, it's Daryl. I'm reading the wrong line here. Daryl Parker, and from California. He says, I'm a C4 quad tetraplegia. I was able to go skydiving last year. Now, you would never get me in a skydiving anymore, because if I was 20, I would do it. At my age, no way. But he says, greatest thing ever, but would not have been possible without the encouragement of scholarships and all those things that was able to allow him to do that. Daryl Parker out in California, good for you. I'm living through you. I would never do it, but good for you. So thank you again. Living Well with Dr. John. I got the awesome Linda Schultz here. She's helping me out with this talk, and I hope you guys enjoy it. And we will see what we'll bring up next month for you. Thank you.
Thanks for having me, John.
Thank you again, Linda.